for coming in and staying to the bitter end with me. Not to say that all of you will be staying to the end of this lecture. It's okay. I don't take it personally. That's why I make my... Oh yeah, I'm sorry. Wow, that's a long time to sit down and listen to a lecture. Thank you for letting me go first, Ham. Okay, so we're going now. But I mean, I could just be lecturing to Dr. Ferris, but that wouldn't be, we could just be sitting here lecturing to each other. But it's a lot more fun to have at least a few people here to talk to nod and smile at me, even if you're not paying attention. I appreciate it. I really do. Okay, we're gonna go to the midbrain. Woohoo! The midbrain. There are things about it that are easier. There are things about it that are tougher, but it's the end. So, and you already have all the information sitting right there in front of you. So here we go. Here are your learning objectives. Here are your links to the learning objectives. Here's a question. Which of the following lesions would you expect to find or see a loss of contralateral vibration and 2-point discrimination deficit? That is a bad question, but hopefully you can figure out what I'm trying to ask. I just wrote this one upstairs. Like I need another question, so let's see if I even know the answer. Which of the following lesions would I start the final loss? Oh yeah, I remember what the answer is. All right, so where's the nucleus that has vibration, proprioception, 2-point discrimination? What's the nucleus, the tract you're looking for? The medial lemniscus, fantastic. So in the medial lemniscus, is it in 1, 2, and 3? Yes, because it's all the same picture. There's another question. No, there's a reason why I said. There's another question that I have in here where there's different areas of the brainstem. So bear with me. Wow, it's all the same picture. All right. So where is the medial lemniscus? Let's see what you all put. Most of you put 3. Is 3 the right? Oops. Oh, I don't have my check. Oh, I'm sorry. 3 is the right answer. So the medial lemniscus. In this part of the brainstem, what part of the brainstem are we in? Anybody? Where do you think we are? The pons. Okay, why do you think you're within the pons? It's going to lie down. Yeah, all right, and that's where it lies down. That's right. That's one good reason. Any other reasons? Horizontal fibers, right? So we have these pontocerebellar fibers that are running horizontally. Another reason, anybody? Fourth ventricle. The fourth ventricle is here, and it's open. So this is the floor of the fourth ventricle. Anything else? Any other things? Anybody points out that from the last lecture? I know it was the last hour. Anything on there that is pond-like? No? Okay. Well, the basilar part of the pons sticking out here, that's pretty big, and no other part has that. This internal genu, the facial nerve wrapping around that nucleus only really happens, it doesn't wrap, no fibers come around diagrammatically and wrap around. So those are some other things that hopefully can clue you in. You're in the pons. All right, so the medial lemniscus is going to lie down. It's in this location. It's going to end up being horizontally. It started off being straight up and down, and so it doesn't really change a whole lot about the region or zone it's located in, but it's going to be in this area. And so the only lesioned area that includes that tract is 3, and most of you put 3. Okay, we're almost there. So the mesencephalon doesn't change as much as the other parts of the neurotube throughout development. So it looks very tube-like, kind of in the end, all right, I guess. But that's what they say. But for me, the thing that helps is that the ventricular system is just going to be the cerebral aqueduct because of the growth isn't as much, and so it's really much easier to point that out. The only thing it can be confused with is the closed part of the medulla oblongata. So you need to trick yourself and go back and forth between those two, okay? And so it's the most rostral aspect of the brainstem. And so here you have the development here. You can see that a couple special nuclei, neuroblasts, migrate out from the alar plate and set up residence in this area called the tectum of the midbrain. And these are going to grow into pretty large bodies that are filled with neurons that we call the superior and inferior colliculi, okay? And the superior colliculus, or colliculi plural, is going to be related to visual function, and the inferior one is going to be related to auditory function. And luckily, you know, your eyes are just a little bit above your ears, and so hopefully that will help you remember which one is which, because that's what helps me remember which one is which. Okay. And then so here you have some other high points of this midbrain. The mesencephalic nucleus, although it started in the pons, is going to also reside here in the midbrain, in the mesencephalon. We also have growth. We have neurons that grow out from the basal plate, and they take up residence about like the ventral medial aspect of the midbrain, and it's a nucleus that you're going to be able to see pretty readily in not in all the sections of the midbrain. But that nucleus is called the red nucleus, and it will be important later on. And cranial nerve nuclei that are important in the midbrain are the ocular motor nucleus and the trochlear nucleus. Sure they are. 1, 2, 3, and 4. 1 and 2 are exceptions, so just 3 and 4. Cranial nerve nuclei, right? You have some of 5, because 5's in all of it, but that's the mesencephalic. Yay, we're to the top. So there's no more cranial nerve nuclei to go. All right, but you also have reticular nuclei, and you have other nuclei, Raphe nuclei. You have paraqueductal gray and things that are going to become more important later, but they do have to show up here, and we'll talk about them briefly. And another important highlight of the midbrain is an area called the substantia nigra, which is a collection of neurons, and I have a little clinical application here in a minute. So that is going to be kind of between the tegmental area and the area where you have these fiber tracts that are like corticospinal, corticobulbar tracts, and we'll go through this in a minute. So the collection of axons that are traversing up from the brain, down from the brain, the cerebrum, and coursing to the cranial nerve nuclei for motor. Those are called corticobulbar, and the corticospinal going all the way to the spinal tract. They're going to be included with some other fibers. I'm only going to talk and introduce you briefly in this area that is called the crus cerebri. So the crus cerebri is the part of the midbrain that has those axons, the big bundle of axons, okay? And you're probably going to hear that term multiple times. So where does the midbrain end up residing? It ends up residing just inferior to this diencephalon. It's got new neighbors. It's not going to have the basilar part of the occipital bone and the cerebellum as neighbors anymore. It's actually going to have different types of relationships. And you can see that depicted here. Here's the midbrain, and where it's situated sort of higher up, and when you're looking from this inferior view, what seems to be deeper into the brain. And so you can see the vasculature, the dense amount of vasculature around it. And when you think aneurysms, where you have vasculature that the walls bulge out and cause these big kind of balloon sections, you can see how you could have maybe some problems with structures such as cranial nerves 3 and 4 that will be leaving the midbrain. So its neighbors are going to be neighbors like the temporal lobe. So hopefully you've started to lay out the different lobes of the brain. The temporal lobe is going to be just lateral to the midbrain. The optic chiasm is an important structure that's going to be anterior to, and you can see that in this other diagram. When you're looking at a medical image, you can see those neighbors on this horizontal section. Here's the optic chiasm, here's the midbrain, and here's the temporal lobe. A lot of people say the midbrain reminds them of Mickey Mouse. So when they're looking at a medical image and they're looking up, you're going to scroll through an MRI and you look for the brainstem looking like Mickey Mouse, and you know you're in the midbrain. It works for me too, so I go with it. Why not? All right, I'm from Florida. I've been to Disney World many, many times, and so I have a soft spot, I guess, for Mickey Mouse. All right, so the features, it doesn't have a lot of features on the ventral side. Actually, it doesn't have a lot of features on the dorsal side. But on the ventral side, you see those large bundles of axons here called the crus cerebri that are kind of sticking out. And that should clue you in that that's the area of the midbrain. The mammillary bodies, all know, are going to be close by, but they're not technically part of the midbrain. And you also have cranial nerve 3 coming out of the interpeduncular, so between the cerebral peduncles, the fossa, the interpeduncular fossa. So don't forget that cranial nerve is that close, because if you have any types of lesions, or you have any kind of mass, or you have any type of bleed, it's going to affect all of these structures. You also have cranial nerve 4, which is smaller than this, substantially smaller than this in relationship to cranial nerve 3, but they drew it this way so you could see it coming around from the dorsal side, and it does come onto the ventral side through its course forward to the orbit. And here's the area I just showed you on an MRI. This is a sagittal section, and this is the interpeduncular fossa, and so this is the area of the midbrain. You can see the cerebral aqueduct, the very thin canal here. On the dorsal side, the nuclei that came out from the alar plates are going to develop into those colliculi I told you about, superior and inferior. You're going to see those on the dorsal side. Okay, so that's what you look for. You get really distracted. Everyone gets distracted when you look at the posterior aspect of the brainstem by the rhomboid fossa. Oh, it looks so just crazy. There's all these bumps and all these things. But don't be so distracted that you forget that the midbrain's way up here. It's above the rhomboid fossa. Rhomboid fossa, we're thinking pons, medulla oblongata. You got to look above that diamond to see those colliculi bulging out from the midbrain. Another observable anatomic feature is going to be the trochlear nerve coming out of the dorsal side, okay? And the trochlear nerve is where it comes out and wraps around, is demarcating the transition between the pons and the midbrain if you're looking on the dorsal side. So it helps you see where that transition mark is. Well, it helps me understand that at least. And then another point is not part of the midbrain, but it's sitting there right nearby, and so it could be relevant to you and your patients, is the pineal gland. You remember the pineal gland is one of the endocrine glands. It is going to release melatonin, and it's going to be located just medial to the collicular, although I kind of see it sometimes sort of up here. And cysts are a common problem in pineal glands. And you can sometimes have pineal tumors like this one here, and you can think about having a tumor in that very small area that would be here. It could push down on the tectum. These colliculi could push this way and cause obstruction of cerebrospinal fluid through the cerebral aqueduct. So that's not a hard stretch to understand how that could occur. Okay. So don't forget the ventricular system is now transitioned to this very narrow cerebral aqueduct, which helps you identify. The internal anatomy of the midbrain. Now we have 3 regions. We don't just have a tegmentum area and we don't have a basilar pons. We have a tectum, which is the roof that didn't turn into the cerebellum, it turned into colliculi. We have the tegmentum, which is the area that has all of the cranial nerve nuclei and such. And then we have what's called the basis pedunculi. I don't care if you ever call it that. You're probably going to resort to cerebral peduncles in the end, but anatomically, I couldn't be an anatomist and live with myself if I just said cerebral peduncles all the time. And I'll tell you why in a second. The tectum is, when you're looking at a cross section, you need to get yourself oriented this section because everyone asks me that. I think if I had $1 for every time someone asked me where the tectum was, I'd be rich. I wouldn't need to teach anymore. So over here, when you're looking at a sagittal section or a half brain, look for that tectum. Look for those colliculi because they look totally different like this than it does looking from the dorsal side because you can't see the bulges in the same way. If you're looking at a cross section, which you're going to spend a lot of your life doing here in the next few weeks, the tectum is going to be in this location on the other side of the cerebral aqueduct, on the dorsal side of the cerebral aqueduct. Now you got your orientation, okay? The tegmentum is going to be the middle area, really medial area, although it does come out laterally here. So everywhere from the tectum, so you draw a line through the cerebral aqueduct and you come ventral, but you don't include the substantia nigra or the axons that are in the cerebral peduncle. So the basis pedunculi is the rest of the midbrain that's not included by the tegmentum or the tectum. And so the cerebral peduncle actually represents the entire midbrain ventral to the tectum. So when you say cerebral peduncle, what you really mean is all of this and all of this. And when you're looking at the peduncles from the anterior and you're grabbing one, you're grabbing the tectum too. I mean, you're grabbing the tegmentum too. You're not just grabbing those outer axons, which is really what you're trying to say when you say cerebral peduncle. The substantia nigra and crus cerebri are the basis pedunculi. Like I said, in the end, I don't care, but I wouldn't be an anatomist if I did it that way. Okay. So, which of the following would you not expect to see in a cross-section of the midbrain? Okay. Make your selection. 5, 4, 3, 2, 1. Okay, so most people put the nucleus ambiguous, and that is the right answer. The medial lemniscus, that sensory tract coursing up, still going to be there, okay, because its target is the what? Thalamus. What part of thalamus? The VPL, right? All right. Woohoo! The corticospinal tract is still going to be there because it's coursing down from the cortex, which you'll learn exactly how it gets there shortly, or unless you already know. I don't know if you already know. And it's going to course all the way down and to cusset or cross and the medulla, and is headed towards the spinal cord, right? The ventral horn mostly. The anterior lateral system is still going to be there because it started in the spinal cord and it's coursing all the way up to that thalamus as well. The nucleus ambiguous is not going to be there because that is a nucleus that is going to give motor innervation to what? What cranial nerves is that nucleus going to have fibers contributing to? 9 and 10. What's the function of that nucleus? Swallowing and speech, right? So you have hoarseness and dysphagia. Okay. And the medial longitudinal fasciculus, I knew that was going to be the next top choice because it's kind of like, I don't know what that does. But it is going to be a big player here, more of a player here, because we're talking about nuclei that are important for moving eyes, and we need our eyes to move together, and a medial longitudinal fasciculus is going to be a way that occurs. And we talked about it a little bit earlier. I have a slide on it, give you a little information, and another professor is going to give you the nitty-gritty on it. But I don't want you to forget it, because Dr. Wyand paid me to make sure I threw it in. Okay, so the nucleus ambiguous is the right answer. So don't forget, we have ascending pathways in the midbrain. We have descending pathways in the midbrain. I have them spelled out for you here. So let's do the anatomic regions of the midbrain. You can take, caudal and rostral. We do have rostral, but it's a little bit easier to talk about slices of the midbrain at a couple important points, kind of like in the medulla where you have motor decussation. If I just did caudal medulla and you have two big things happening, a motor decussation and a sensory decussation, you kind of lose out on understanding that those things are there. So for the midbrain, it's kind of similar. I don't just have caudal, middle, and rostral because we have some anatomic points that are important. And I have tangents on the dorsal raphe nuclei of the midbrain and the reticuli nuclei of the midbrain, specifically for this region that you can watch later. I'm not going to present them to you right now, but they're important. Okay, so in the caudal midbrain, you have a structure called the inferior colliculus that developed from that alar plate, okay? That's the bulging bump on the dorsal side, the one on the bottom or inferior that's associated with auditory function. Okay, great. And so you can see a nucleus there that's kind of ovoid or egg-shaped, And that, what you would call that the inferior colliculus, it's a nucleus. And then you have some fibers that sort of hold it. They talk about like a goblet. Now these are axons of the lateral lemniscus, which I have some information embedded in here if you want to understand what that's for. Not super clinically relevant. Okay. In the tegmental area, we have a lot of stuff going on. We have the trochlear nucleus. So 3 and 4 are going to be in the midbrain, and here's where 4 is located because we're at the most inferior part of the midbrain, and 3 is going to be higher and 4 is going to be lower. Or they would have named it differently, okay? Or numbered them differently. So we have the trochlear nucleus that is sitting right on top of that medial longitudinal fasciculus because its function is to help with coordination of eye movements. And then you have the ever-present here central tegmental tract, which you need to hold on to where it is, again, for all of this function, but you don't need to worry about its function in regards to doing sensory and motor deficits right this second. The medial lemniscus, friends, is here, and it has put its feet up. So it's the head, the upper regions for sensory are actually down here, and the lower parts for sensory are going to be upwards, and it's now very closely related to the anterior lateral system. So now they're really close friends. Where the anterior lateral system was close friends with the cerebrospinal tract throughout a lot of the rest of the brainstem, now it just decides, you know what, I'm meant for the medial lemniscus. And that's not really surprising because they're going to the same place, right? Yeah, sure, they're headed to the thalamus together as friends. And then at this inferior colliculus level, we have, although the superior cerebellar peduncle doesn't necessarily attach to the midbrain, we do have the decussation of the fibers that occur in this region, and you're going to go through that pathway. It's going to be functionally important when you're talking about lots of different controls for the vestibular, getting information from the spinal cord, and deciding where your body is in position and turning your head and turning your eyes and everything together. Okay. If you're looking next to the cerebral aqueduct, we have an area that's known as para-aqueductal gray, and it actually is this big gray circle area. This is opposite because it's staining axons. And then just alongside, you have the rest of that mesocephalic nucleus and tract that's receiving proprioception information, cranial nerve 5, trigeminal. And now if you look at the basis pedunculi, which is going to have a lot of fiber tracts that I talked about coming down from the cortex and through this region, everything coming down from the cortex and through the region. You have parietal, occipital, and temporopontine fibers that are most lateral on each side. Not super clinically relevant. They're going to the pontine nuclei and the pons and headed towards the cerebellum and those horizontal fibers, but they are there. They talk about it and they point them out, so I gave you a little tiny blurb on it. The frontopontine fibers are going to be the most medial fibers here. Again, these are the two least clinically important parts of this basis pedunculi, and so you're not going to necessarily, also going to pontine nuclei from the frontal part of the cortex. So you don't have to necessarily too bogged down in those details, but the two that you do want to worry about are the corticospinal fibers here in red, which is just corticospinal tract, and the cortical bulbar fibers, axons, that are here in yellow. Because lesions that affect these tracts are going to show up in your patients as motor deficits to the body if it's corticospinal fibers that are affected, and deficits to cranial nerve nuclei function if it's cortical bulbar fibers that are affected. So the cortical bulbar fibers, I introduced them to you yesterday. I'm bringing them up again because this is a place where you get lesions that specifically target, not the only place, but specifically target these fibers because they're all there, right? I mean, we're at the top and the motor cranial nerves are coming down from the midbrain. And if we haven't gotten to all the cranial nerves yet, most of the collection of the fibers going to those nuclei are going to be concentrated in these in the midbrain cortical bulbar fibers. Okay, so a lesion is going to take out a whole lot of cranial nerve, could take them all out at one time if it's going to take out those fibers, those axons. Okay, Clinical application, the Parkinson's disease, I'm sure it's probably already been brought up to you, but it would be remiss if I didn't mention that the substantia nigra has our dopamine-containing neurons in the compact part, and they are associated, loss of these neurons are associated with this disease. I think you have an entire lecture probably, you have a whole lecture on Parkinson's disease, but this is a structure that is important. And you can see it in lab when we look at a cadaveric specimen. You already saw it probably. I probably already showed you maybe in gross where we cut off the brainstem and you could see the stained neurons because of the neurotransmitter dopamine is stained dark, which is why that process of making dopa is similar to the process of making melanin, which we covered in histology when we talked about the skin. Okay. All right. So if we go up a level, we're not at the inferior colliculus, but rather we're at the superior colliculus level, okay? So it looks different. The shape of the inferior and superior colliculus look different. I used to go in the room with a whiteboard with markers, and I used to draw the shape changes so that when I looked at a brain stem slice, of course I had to stand up in front of my faculty and answer questions and draw things and draw nuclei and stuff, and so I was scared to death. And I got to the point where I can just look at a shape and say, well, we're inferior and superior colliculus. When you get to that point, you're going to feel pretty darn good about, if you can look at the slice and you don't even need to see nuclei, just the outline of a shape and say, I'm in the superior colliculus, man, that's a feeling. But I'm sure all of you will get there way faster than it took me. So here we're at the superior colliculus. I outlined that in yellow. It doesn't look quite as ovoid and goblet shaped with that lateral lemniscus tract nearby. So hopefully the shape of the colliculus itself might help you. You still have the paraocular duct around the cerebral aqueduct. You still have the rest of the mesencephalic tract and nucleus. Okay, but you have other things. Some of these are your friends. Some of these you've already met. We're just following them up, and some of them are new. The ocular motor nucleus with Edinger-Westphal nucleus, they're not depicted separately here. They're really seen much more separately at one level above where this picture drawing was made, but they're still just starting. Edinger-Westphal is just starting here. They're collectively put there in yellow with the medial longitudinal fasciculus, which is integrated with the eye movements and coordinating everything. Don't forget that one, is right next door in black. You have some trigeminothalamic fibers, which weren't really pointed out in the book, but they're going to be in this region. So that's how that trigeminal nucleus, the tracts continue up, and they're going to bring sensory information from the head up to the thalamus, and that's where they're located at. And don't forget the central tegmental tract, although I always forget what the central tegmental tract does. The anterior lateral system is still really good friends with the medial lemniscus, where they're going up to, they're almost at the target destination. And so at the end of the medial lemniscus, anterior lateral system kind of sticks out here. Whereas when you think about where it was, the medulla oblongata, it was like way down here, and it was very associated with rubrospinal, and then it ends up on the side of the feet of the medial lemniscus. Okay, so that's medial lemniscus. Cerebellothalamic fibers, so we have fibers that are going to the thalamus from the cerebellum, and I just sort of highlighted those are kind of more in the other category for you at this point. Then we have these really large nuclei close to the midline, one on each side, which is called the red nucleus. And it will be important for you when you talk about the cerebellum, you talk about motor tracts in the body, and you'll understand its complete function. But right now, it helps clue you in that you're at the superior colliculus. And so I do have some information on there, but at this point, it's just more of an orientation place for you. Now, the basis pedunculi has the same tracts that was in the other part of the caudal aspect, inferior colliculus at midbrain. No, we don't have any new players here. So yay, I don't even have to point anything out. Now, as you come very, very close to the diencephalon, there is a transition in a lot of structures, some of which I'm not sure that you've really talked about yet. So instead of me just saying words of things that you don't know what they do and where they are, I wrote out a little tangent of the anatomic transition. And when you get to that point, where you've done the diencephalon and gotten your orientation of its anatomy, you can read the tangent, and then it'll be like, oh, okay, now all of that, I know what these words mean. But at this point, it would just be kind of just me talking, and I don't like to hear myself talk enough to do that for you. But you do have some important nuclei at this transition that do come into play called pretectal nuclei, and you'll talk about that at length when you talk about the visual system and reflexes. I have a couple stroke personal stories because patients aren't patients, they're people. And as you know me, I like to put a lot of personal stories in my lectures, and although I really don't want to sit here and play them for you because it's not necessary, I looked at lots of them, and I picked a couple of them from people who had brainstem lesions, who wanted to talk about their story and how it affected their lives, and people who had brainstem lesions who have lived and rehabilitated through the process. And I think that if you had a moment and you still want to keep your mind on the topic, but yet you really don't want to just sit there and look at the same things you've been looking at, go ahead and switch over to one of these stories, because they're pretty good. I watched them and I thought they were pretty good. All right, the arterial supply in the midbrain is a little more complex than the pons and the medulla oblongata because it has a lot of neighboring arteries. And you remember, like, the arteries really of anywhere in the body, no matter where that artery went through, it could have little extra sprigs that's going to come off of it and go to a muscle. And we're like, oh, those are just muscular branches, right? Well, I know. They call them all names here, except for like the penetrating ones. So it has a lot of arteries. If you look at the next picture here, do you see all the arteries that are coming in this area? So we have posterior cerebral, we have internal carotid that's coming up with anterior and medial choroidals that are coming off, and all of these arteries are going to play some role in bringing blood to the midbrain. So it's not quite as easy, clear cut, oh, it's going to be paramedian branches, or it's going to be long, or it's going to be short circumferential. We're talking about there's a little bit of whatever's around is going to bring blood supply. But there still are some lesions that you can, classic lesions that we can learn, one of which is the superior alternating hemiplegia. So we have a lower alternating hemiplegia that's associated with sensory and motor deficits on the contralateral aspect of the body, but a cranial nerve deficit on the ipsilateral side of the body. We have one in the pons, and now we also have one in the midbrain, okay? And this one's also commonly referred to as Weber syndrome. So it's usually the posterior cerebral artery that comes, basilar ends as posterior cerebral. And as it comes off, it has branches that are going to come off of it, and they're going to bring blood supply to the midbrain. Well, P1 being the first segment is going to supply this area. So if we have a lesion in this area, we have an occlusion, we're going to lose this part of the midbrain. So what is going to be affected? The exiting root of the ocular motor nerve, okay? The ocular motor nucleus is way up here, but that nerve comes out of the midbrain and it comes through that area. We also are going to lose corticospinal fibers being these, and the crus cerebri. We're also going to lose cortical nuclear, or also called cortical bulbar fibers, that are also in this area. And these are the other fiber categories, not quite as clinically relevant, but these two you're going to see signs in your symptoms, in your patients. Signs like loss of ocular motor, so that eye is going to be down and out and dilated, right? We've been doing that since the third block of gross anatomy, down and out. All right, great, loss of ocular motor. You're also going to have some loss of the motor function because corticospinal in the contralateral extremities, because of the cortical bulbar deficits, the loss of motor innervation to cranial nerve nuclei. You could have a variety of cranial nerve deficits, and I just put a couple up there here, okay? That's just an example. So that is the Weber syndrome, which is located more peripherally, more ventrally. But you can also have a lesion that is more medial and doesn't involve the corticospinal and cortical bulbar fibers here, and it can be in this location here. And this is called Claude syndrome, and that's kind of is the most common term for that lesion that I could find looking through the textbooks. And that is going to damage the ocular motor nerve coming out, not the nucleus, but the nerve. The red nucleus, which is going to be a relay point to the cerebellum, and cerebellothalamic fibers. And because of that difference in the lesioned area, you don't have the motor loss of corticospinal and corticobulbar, but now you have some cerebellar fiber involvement, and so what you see is some ataxia, tremors, and incoordination maybe in patients. You might not know exactly why at the time, but you know something is wrong, and it's coupled with ocular motor nerve deficit, and that's what should signal you. It's the fact that you have those cranial nerves are the localizing features of brainstem lesions, because the nuclei only are in certain areas, and especially great if they're the ones that are only in one area. So if you're reading any question at all, that should be the biggest red flag that can be put up is a cranial nerve lesion. Cranial nerve deficit. Okay. And the last one is Benedict, and Benedict includes both of the first two lesions, basically them together, because it's a larger lesioned area. And so what you get is the same symptoms as Claude, but you have additional deficits because cortical spinal and cortical bulbar fibers are affected. So you get all of those deficits together. All right, so which of the following lesions would you expect to see in a patient with a loss of pain and sensation, I meant temperature, from the ipsilateral face, dysphagia, didn't define it for you this time, and loss of pain and sensation from the contralateral body? So we have 3 different brainstem slices up here. Okay, make your choice. 5, 4, 3, 2, 1. Okay, so most people put 2. Do I have a clicker? Yes, I do. That's the right answer. All right, how did you know it was 2? How did you know it was the middle section? Anybody? Yeah.
Dysphagia.
Dysphagia. Okay. So that really helps you because you knew that it was which nucleus? The vagal nucleus. Okay. So what nucleus is it called though? Huh? No, it's okay. Nucleus ambiguous, right? Right. What's the dorsal motor nucleus? I mean the motor nucleus of vagus do? Parasympathetic simulation, right? Motor. Okay, so nucleus ambiguous is going to be dysphagia, and it's going to be hoarseness. That's what questions read, or problems with speech and swallowing. So the nucleus ambiguous is only in this section. We don't have it in this section. Why? Because it's not in the pons. Okay, and we don't have it in this one because it's not in the midbrain. Okay, so that is the one thing that really helps. Why do you have loss of pain and temperature from the face? Is because of the trigeminal nuclei here. Why do you have loss of pain and sensation from, what I was thinking, I meant temperature, from the contralateral body is because of the anterior lateral system, which is right here. And so you can see how you're going to start to put these lesions together, especially if the professor writes the question correctly, and you're going to be able to work through these problems. So go with that. Now, there are some important herniations that affect the midbrain, and this picture's got lines all over it, and I could spend about 45 minutes taking them out for you, but I don't really need them. It doesn't matter. What I want to show you is that if here is the midbrain, which is right below, but that's okay. Let's just say that it is. I'm looking down, it took the midbrain off. Can you understand how having an increase in mass in this area, anywhere, is going to push the brain inward and downward? There's nowhere else for it to go. It cannot go outside of the cranium. The only thing the brain can do, if bleeding, increased fluid, because of swelling or increase because of a mass, is push this way. And what's in there? The midbrain gets squished. And lots of you have had that in your cadavers. And so it couldn't be for any reason: hemorrhage, mass, increase fluid because of edema, okay? The one that happens, and I know I saw, if you took your cadaveric brain out, the midbrain was all squished and deformed. It's because it had a central herniation. The brain was pushed downward and it squished the midbrain. So I have some examples for you. I'll bring them when we do lab. Okay, and I have there's some symptoms that show you and give you indication that you have early and late progression. This is going to be talked about by other people. I just sort of gave you the skinny and gave you the importance of it, but you have other faculty who will take you through these steps and talk about the red nucleus and talk about tracts that are taken out in the progression of the herniation such as this that are important. You can also have expansion of something in the posterior cranial fossa, which gives an upward pushing on the midbrain. So that's called an upward cerebellar herniation. And so here you have the tentorium cerebelli here, and you can see how you can expand. If anything, bleeding or a growth, a mass, could push up and cause symptoms and compress the midbrain. So if you find out early enough that you can do something about it, usually the outcome is good. Another very common herniation that you're going to see in certain patients is called an uncal herniation. Here is the uncus of the temporal lobe, and the uncus can, because of like this other picture here, the uncus would be right here, and it can just, if you have increased pressure, it'll slip through and it'll squish the midbrain. And so that's called an uncal herniation. And look what's nearby, cranial nerve 3, just doing its thing. It's just going right by. And then you have this uncus that comes over and squishes it. So you can have some early symptoms of these herniations that can just be represented by cranial nerve deficits. Might not be a brainstem lesion. It could just be a cranial nerve deficit because you have something occurring, shifting of the brain. And this is a medical image which is showing you an uncal herniation here, where you have the midbrain shown here. That's all from me. I will see you in lab next week. Lab. Lab is, I'm glad I have this recorded. Hopefully people watch it. And I guess we should send it in a word form on an email just in case people don't watch my lecture. Bring your computers to lab. Lab is, I meant to bring mine and show you what I didn't. It is a computer software interface. So you will have a specimen and you will have a computer software program, very similar to how I did histology labs. So you have like this PowerPoint that you open and you can go along and there's links and you go to the next structure and you look up an example, and I'm going to walk you through looking at different parts of the brain, okay, through these different stations. So when you come into lab, you'll be in groups of 4. And you'll be at a station. You may come in and you're at station 3. You didn't need 2 and 1 to do 3. You just came in and you were given the assignment of being at station 3. You have a certain amount of time that you have for that station, and then we rotate to another station. They all have different specimens and they have different objectives. And it's to make lab coordinated and organized, the objectives clear, and you have certain structures that you know you need to be able to identify, and then you're done. And at the end of lab, there's a quiz. And it's not like I'm going to ask you to look and point out the central tegmental tract, but hopefully you'll be able to find the inferior colliculus, okay, and things like that. Yes?
Will you say on the recording regarding clothes
I'm going to wear something like this. So yeah, you don't have to wear scrubs. You can wear scrubs, but you know, this is neuro. We don't. You take a step up here. Yeah, the specimens will be removed from bodies. There won't be any saws or anything. It's just going to be a clean, you know, put gloves. We'll have gloves for the specimens that are wet specimens, we have some models and other things that you will use. And there'll be a few of the space stations where you're learning things that you don't have to have a specimen for, but most of them you do have a specimen, and it's just meant to help you get through and get the foundation of neuroanatomy and have that interface with the specimen again, because this is really 3D stuff. And we're not going to talk about just the brainstem, we're going to go into the rest of the brain too, okay? And so the quiz, what you wear, bring your computers, bring your blue cords. Anything else? Be on time. Because I have it timed to the minute. I mean, we're timed. This is an organized fashion, and it's this way so that it's as short as it has to be for you. Okay. So if you're late, I'm sorry. I'm trying to make everything. You have to be here the least amount of time that you need to be to get what you need done, and then you can use the software, computer software, to review afterwards when you don't have a specimen, and you can still refresh your memory on neuroanatomy. All right, that's enough for me. I will see you next week. Thank you very much. I'm going to turn it over to Paris. 10 minutes or what? Or 10 minutes? You need a little break. Okay, thank you.